right, hello, my name is Hannah Landis Sparks, and today I'm going to be having a discussion with Dr. Murphy. Today, I wanted to ask you a few questions. I'm doing an investigation in psychology and psychiatrics in the ER and what the ER's role is in psychiatric care. Let's start off with a little bit of your background. What led you to working in the medical field early on?
Well, I think it was my purpose in life because I never wanted to do anything else. My parents always said when I was just a toddler and could talk, I always wanted to be a doctor. I just remember that as being my goal.
What kind of education did you have to complete to get to your doctorate level?
Well, I had 4 years of college. I could have done any major, but I chose chemistry and biology. And then I went to medical school for 4 years. The first 2 years of medical school were sort of like college work, book work, lab work. I started hanging out in the ER just to be in contact with patients, stitching up people and things like that, because I was ready to be a doctor, not be a student. After medical school, I joined the Army for a 1-year rotating internship. When I got out of the Army, I didn't have any specific plans. I wanted to be a surgeon. The specialty in emergency medicine didn't start till 1980. And so I got out of the Army in 75, so I'd already been working for 5 years. And working in the ER is training. You get a lot of experience. When it officially became a specialty, because of my practice experience and so many hours of ongoing continuing education, I was eligible to sit for the boards. So I took the written board first, then the oral board, and I passed those. So in 1983, I specialized in emergency medicine.
Wow, okay.
Based on practice experience. They called it grandfather in for the people who had worked in the field for years.
After 83.
Most of the time I worked in the ER, I was the only physician on duty, so I was kind of the captain of the ship. The nurses and ancillary staff didn't work for me, they worked for the hospital, and I worked for an ER contract group as an independent contractor. But I was in charge of everything that had to do with patient care. Being captain of the ship goes with the full responsibility for your patients.
That's a lot of responsibility. In your experience, what are the traditional protocols in emergency medicine for addressing suspected mental health crises and disorders?
Well, they don't, in my experience, they don't really have a set of written protocols for most things. There's just some standard principles of care that are taught in medical school and through experience. It's just kind of the doctor in charge kind of followed what he thought was appropriate for each situation. Every situation is different, and if you have strict rules, sometimes that can set you off in the wrong direction too. I've seen that happen. I've had a case where a lady came in with a severe headache and chest pain, and the nurse asked her, "What are you here for today?" She said, "I'm having chest pain." And the protocol for chest pain was to give them aspirin. Well, it turned out this lady had a cerebral hemorrhage, and aspirin was not the best thing to give her. So you have to use your clinical judgment and not always follow the standard protocol.
Very true. That is good advice. How common would you say it is, or was it in your experience, for people to visit the ER during a mental health crisis of some kind or related?
I think it's very common. There was a study done that said about 25 to 30% of ER visits have some form of mental health issues involved. It could be anxiety, which is one of the more common ones. People that are anxious, who have a lot of drug and alcohol problems.
A lot of the drug and alcohol are related to psychiatry, psychological problems.
A lot of people with depression get involved with drugs and alcohol. Depression is very common, suicidal ideation is very common, suicide attempts are common, and then sometimes you get into people that are psychotic and delusional, that are just clueless about reality.
Out of touch, disassociation.
Had an elderly lady one time who came in because she had a bullet in her heart. She needed the bullet taken out. So we evaluated her, didn't see any signs of trauma, took a chest x-ray, everything was fine. So I said, well, when did you get shot? She goes, last night.
Oh, wow.
And she was convinced, delusional, that she had a bullet in her heart. It wasn't a danger to anybody, so you couldn't admit her involuntarily. So I said, well, we're going to admit you to the hospital, and the ethnic doctor's going to help you with this. And she refused, absolutely refused to be admitted to a psychiatrist because she needed the surgeon to take the bullet out. So I called a friend of mine who was a thoracic surgeon. He agreed to admit her to the hospital and in a psychiatric consult. So she agreed to that the surgeon was going to be her doctor. So
Interesting.
I never got any feedback on what happened, but sometimes you just have to manipulate the system a little bit to get people help.
That kind of brings attention to some of the blind spots for psychiatric patients who aren't a danger to others and aren't necessarily a danger to themselves. They're kind of left
if they're a
in that
danger.
area.
There's legal system that allows you to
do something.
get them admitted temporarily for an evaluation. In that evaluation, they can determine if they need longer-term care or if they're stable enough.
To your knowledge, what were some of the more frequently observed mental illnesses or disorders that you saw come through your doors and you handled?
I'd say probably drug and alcohol related. People would come in intoxicated, frequently brought by the police. They're very
Substance abuse
agitated
disorder.
and disruptive, and the policemen need a medical clearance before they can take them to jail. They rule out some kind of medical
Gotta check them
problem.
before they take them in.
So we see a lot of people buy street drugs and have bad reactions to them because you never know what you're getting off the street, and they start hallucinating and doing things like that. You just kind of have to calm them down and eventually let them go home and offer them some kind of follow-up if they admit they have a drug problem with hydrocodone, and they say yes, and I say, well, are you willing to get any help for it? And they say no, and I say, well, there's nothing else I can do for you.
True, that is a problem with many people.
So it's frustrating sometimes. But if they're threatening to kill somebody and they have a definite plan, like they have a gun, they're going to shoot themselves, or they're going to jump off the bridge into traffic, then you can get a involuntary hold on them for up to 72 hours in Texas. You get the order from a judge in the middle of the night. You make arrangements for a facility to take them as an inpatient, and then the sheriff will transfer them.
Okay.
In custody, so that there's no danger of them hurting themselves.
That is definitely something to look out for, especially with some of these people dealing with depersonalization, with drugs or other things.
Some of these people are very manipulative people.
Not true.
And they
can be.
I've had them come in for suicide attempt, get them admitted to the medical floor. They stabilize, transfer them to the psychiatric floor. The doctors let them go home in 2 days. One person was a nurse who knew all the questions and all the answers, and she talked herself talked the doctor and let him go home, and then she immediately killed herself. So that can happen. You can't predict those things.
No, you can't. Everybody tries their best, but unfortunately that is something that's left up to the person. So to your understanding, what do you think are some of the common underlying reasons for the prevalence in some of the most common mental illnesses you saw come in?
Well, I think drugs and alcohol have a lot to do with depression, unhappiness, lack of spirituality and direction in their lives, so they try to self-medicate. And alcohol, there's certainly genetic links to some of these mental illnesses like depressive disorder,
Definitely.
psychosis. Those can't be helped by the people, but I think that it's difficult to treat some of those, and some of these people don't realize they have a problem, and if they're not willing, like an alcoholic, if they're not willing to get help, you just can't help them.
And unfortunately, some of these people, especially with genetic predispositions, if they never became an alcoholic, they would never have those issues manifest in some cases.
Unless they have suicidal thoughts. Some depression, especially in younger people, are manifested by self-mutilation. They'll start cutting on their arms, not cutting enough to do any real harm, but it's probably an attention-seeking thing, or it's a cry out for help. And, their mental illness is very difficult to deal with. Personality disorders, which contribute to a lot of mental illness, like narcissism and things like those, there's no treatment for it. There's no effective treatment.
Borderline personality, there isn't really anything that
is very difficult to manage.
That's a good insight, thank you. Let's see, somebody's had panic attacks and they're coming into the department.
From a patient's perspective,
what kind of things would that person go through?
They would want to get some help. If they came in voluntarily, they're asking for help. Sometimes they're brought in by friends or family against their will, and then they tend not to be real cooperative. I've had cases where people were in a hyperventilation state of anxiety. Sometimes you can talk them down, put a little brown paper bag over their mouth and let them rebreathe the carbon dioxide that they're producing and raise the level back up in the body. That will help stop a lot of their anxiety because they feel like they're suffocating, because they're breathing too fast. And if you can get them, talk them down and calm them down that way, sometimes it requires medication to calm them down. And then in one case we had to actually put this lady in the hospital and put her on an IV drip of medication because the medication we needed to calm her down.
Would that be something like if you have a patient come in with psychosis and they are being combative?
Somebody that's very combative and delusional and fighting, you have to sedate them. And there's different medicines to sedate them with. You can use something like Vistaril, which is an antihistamine with a sedating effect. It's relatively safe. That's been used a lot and it helps. It doesn't knock them out. It just makes them tired feeling. In other cases, you have to, if they're so agitated, you have to actually paralyze them and intubate them, and just to control their aggravation and anxiety. I had a patient one time that was drugs. He was running through the streets naked in Richardson, and it was cold weather, like 24 degrees outside. He ran into the side of a police car. Picked him up, took him to jail, and his condition started to deteriorate, so they brought him to the ER. And there were 2 policemen, 2 paramedics, the ER staff, and this guy was so combative, it took everybody to restrain him. And we finally got him restrained to where we could start an IV and give him some medication to calm him down. But one of the nurses got injured when he punched her in the jaw, and it can be dangerous. So
definitely.
I don't know the outcome, because once they get into those conditions, they get admitted and you don't ever see them again. Sometimes you don't ever get feedback.
Yeah, that is one thing about the ER. You never know. I have no idea.
In really interesting cases, you can always seek out some follow-up care, but you don't always get it.
Very true.
I've had people come in that were very intoxicated and belligerent and uncooperative, that had like a laceration on their head, and then they come back 4 or 5 days later to get their stitches out, and they were so embarrassed that they didn't even remember the ER the first time.
Wow, interesting. Yeah, that is some things that unfortunately a lot of these people, when they're experiencing these bouts, how often did you deal with combativeness and aggression from patients?
Real often. I've had some drunk people that were very disruptive in the ER, that would bang on the walls of the room and say inappropriate things and disturb other patients in the ER.
Were there any sort of protocols or training that was initiated or followed to protect staff and patients from dangerous and aggressive?
Well, the nurses may have had some training. As a physician, didn't have one.
Interesting.
There was a two police officers that brought a man in on handcuffs who had mental illness, and he caused a scene somewhere, and they arrested him and brought him in. He calmed down. So they stayed in the room with us and they took his handcuffs off. And I asked him a couple of questions about his psychiatrist, and he got mad, jumped off the table and took a swing at me. He missed and hit the phone on the wall behind my head. They immediately took him down, put him on handcuffs, and took him out.
Right.
That's the closest I ever came to being physically attacked by a patient.
Oh, okay.
I've had them threaten me, but
I've heard that's pretty lucky in the medical field to make it through and not be physically assaulted at least once. Very true.
in med school there was somebody in surgery, and another person came through the surgery room with a loaded gun looking for that person to finish it off. They got stopped.
I think I've seen TV shows like that.
When I was working in Tucson, Arizona, there was a guy that came in the front lobby and sat down. The people there asked him if he needed any help. And he goes, "No, I just came in to rest a little bit." And he sat out there for 30 minutes or so and got up, went in the bathroom and shot himself in the abdomen. So you can't predict.
No, you can't. That is one thing, is that medical field and all your training can prepare you, but can't prepare you for the unknowns of the universe. So what are your cases that you experienced that were mostly due to psychological conditions? What do you think the outcomes were after your patient care of that, after you were done with them?
It's hard to say because you don't get a lot of feedback when you're in the ER.
What
It's
your
not
outcome with your last bit of them, transferring them out, or
Well, either you would consider them not a risk to themselves or others, and if possible, you could arrange some kind of outpatient follow-up for them, not just turn them loose on the streets. In other cases, they were obviously admitted, some cases under involuntary admissions under court orders.
yeah, good mix of all those.
Medically unstable patients that were intoxicated or unresponsive from drugs, they usually went to ICU. Not that they were always critical enough for ICU, but there were one-on-one staff and they could watch the person in case they decided to try to leave, self-harm themselves in the ICU. So most psychiatric patients, medical issues generally went to an ICU first.
Okay.
I had a lady one time who had a history of psychosis. She came in really confused and disoriented and delusional, and her friend came with her and said she's been this way and it's her mental illness disturbing her, and she was awake and alert. So we admitted her to the psych floor, and it turns out she had a brain tumor that was causing some of these problems. So it wasn't a mental illness, but
Actually physiological.
you can't scan everybody with an emotional problem, so it's just, that's the way that you admitted her. That was appropriate. She got further care, further evaluation. They discovered the problem there, so it would have been a mistake to send her home.
Do you have any particular memories, like how often you, in your line of work with your ER, being the ER doctor, did you consult and work with any psychiatrists, psychologists, psychotherapists during patient care in the ER?
Well, if they were admitted, you usually contacted a psychiatrist to accept the patient. You can't just stick them on the floor. One hospital I worked at in Athens, Texas, had a system in the county where there were psychiatric social workers on call, and you could call them, and they would come out and talk to the patient and help decide if they needed to be admitted, if they needed to just be medicated and go home. And so that was one of the few places where we had that option. In a lot of places, those people available to come out. A couple of hospitals I worked at did, and it's improved gradually over the years. It's different now than it was in 1980 when
there's a lot more.
1975, you didn't have CAT scans, you didn't have big contrast tests, you couldn't do cardiac casts, you couldn't do cerebral arteriograms. None of that was available back then.
The real nitty gritty of medicine.
Yeah,
Actually
it was
got a
pure
test.
judgment calls back then.
Wow. Do you think retrospectively, if more hospitals had on-site consulting for psychology and psychiatry, that it would have been beneficial in a lot of cases?
I think it would have been. Parkland has a psychiatric ER. But Parkland The recent past was seeing 600, 700 patients a day, and they had it divided into medical ER, OB-GYN ER, pediatrics ER, trauma ER. So, if you have a big population and a lot of patients, then those kind of systems are cost effective. But if you're in a community hospital where you might see one serious psychiatric patient a day or a week, it's not cost effective to have somebody sitting around not getting paid not to do anything right.
Very true. That's understandable. Did you deal with anybody who dealt with a factitious disorder or something akin to Munchausen's?
Probably. There's a condition called neurotic excoriations. People that are real nervous will scratch themselves. It's an anxiety issue.
A somatic manifestation.
It's more common in women. Older women come in and examine them, and they have all these little sores all around on their shoulders only in places where they could reach. It's called neurotic. They have neurosis and anxiety, and they just itch and scratch and cause sores like that.
That's interesting.
I've seen people that come in because they have bugs crawling out of their skin, and they'll sit there and pick them off and show them to you. There's nothing.
So it could be delusional, or in some cases, I was doing some of my research, somatic representation with psychological issues when there isn't any physiological cause like itching.
A lady one time who was acute conversion state, and she was stiff, staring at the ceiling, eyes wide open, and wouldn't say a word. I said, "Ma'am, I'm not a veterinarian. I need my patients to talk to me." She said straight up and said, her friend, "Did you hear what he called me? He called me a dog. I'm not a dog. I don't deserve this." Blah, blah, blah. So she got up, got upset, walked out to the lobby, and her friends calmed her down and brought her back. And then we had an encounter with she's having some mental stress and problems. And so we talked about it, kind of calmed her down, and gave her a referral. So that came out okay.
So I do have one more question. Were there any particular cases that stood out to you that you really remember?
Yeah, the guy that was so agitated and combative on drugs that we had to paralyze and intubate was a memorable case. A lady came in one time who was pregnant with 7 fetuses and couldn't find anybody that would deliver her. We were talking to the history about it, and she'd had a hysterectomy. She'd gone to Bethesda Naval Hospital in Maryland and had a uterus transplant. And then she had in vitro fertilization and was pregnant. And she was like a year and a half pregnant, and she couldn't find anybody to deliver her baby. So we got her admitted so they could deliver her baby.
Oh, that's good.
And I met Jesus one time.
Yeah.
Not in the ER, but I guess he'd been in the ER and got admitted to the floor, and I was in medical school. He told me this story that he'd been staying at the Sunnyvale Hotel in Houston in a room, and a rat in his room.
And a rat got
loose. And he had an ice pick, and he kept throwing the ice pick at the rat, trying to kill it, and finally he stabbed the rat died, and then he felt really bad that he killed one of God's creations. So he took him out on the front porch in the sunlight and laid him on the steps and jumped up and ran off. So he said, I knew from that moment on I had the power of resurrection. I knew I was Jesus Christ. And he believed it.
Wow. Interesting. And he was, when you met this gentleman, he was admitted to psychiatric.
Yeah, he was paranoid schizophrenic. He also told us that there were some rich oil men in Houston that were trying to kill him.
Could be true.
Because of the Vietnam War. They were making a lot of money off the war, and they were fighting in Vietnam because they thought that the China dollar was buried in Vietnam. But he knew that the China doll was really buried in the virgin forest in Texas. And they didn't want him to tell anybody that, and they were trying to kill him because if people found out that the China doll was buried in Texas, the war would end and they'd quit making money. So they were trying to silence him because of what.
Interesting. Oh, that would be scary to believe those things too. The kind of fear these people
You
experience.
couldn't convince him otherwise. Total delusions.
All encompassing. I think about those sort of things and always fear like that would just be so scary.
Yeah.
So scary to truly believe those things. So I think we're about here at the end. Thank you so much, Dr. Murphy. Do you have any words of wisdom for students going into medicine or psychology, the medical fields?
It's different now than it was when I started. There's more control over healthcare from government payers, and compensation is probably not what it used to be. But the personal satisfaction, if you're in it for the money, it's a mistake. If you're in it because you have empathy towards people and you want to help people, then there's hardly a more rewarding field.
Those are wonderful words. Thank you, Dr. Murphy. I think we'll end it on that. Thank you for our conversation today.
Appreciate it.
I appreciate it too.
Good luck to you and your studies.
Thank you, Dr. Murphy.